Welcome everybody to the MSRA Booster webinar. I hope you guys are well. Thank you so much to every single one of you who's joined in advance of the start of the webinar. We're already up to 100 plus. We're expecting around 300 to 400 on the webinar tonight, but it's so good to see you guys all on board. Just give me a yes, guys, if you can hear me, if you can see me, if both of those things are working fine. Fantastic. Thank you very much to everybody who's jumped in and is screaming out, yes, good to see. One last check. I'm just flicking the slides. Just put an X in the chat if you can see the slides flicker to make sure that's all good to go. Fantastic. Thank you so much, guys. Welcome. Thank you for giving up your evening. I know you guys are super busy. You're doing all sorts of different things. Some of you I know are in different parts of the world as well, in different time zones. We really appreciate you giving up your time, your evening or your morning or your afternoon, depending on where you are, to come and join us. It's super to see so many of you guys on board. I know there's been a lot about AKT happening in the last 24 hours, so I can see there's a lot of questions coming our way. So it's really good to see you guys on board. Hopefully we will answer a lot of those queries. Welcome to Dr. Pooja. She's also on board. Guys, any questions, any doubts, any worries, any concerns, any clarifications that you have, please do put them in the chat. We're looking at every single comment, question that's coming in. We've got quite a few already. Dr. Pooja is going to be on throughout the whole webinar answering those queries. If there's any major ones that I can pick up and answer that's relevant to everybody, I will do that as well on the webinar itself. Welcome to everybody who is joining. Guys, can I ask a favor of you? I'm just going to put the link in the chat for the joining registration for today. If you know of any doctors, any friends, any colleagues, any groups, Telegram, Facebook, WhatsApp, anywhere where you think there are doctors who may benefit from this webinar, please do grab that link. Please do post it in those groups, and let's get as many people on as we can and try and help as many people as we can, because lots of change with MSRA. MSRA this year is super competitive. Doesn't matter what specialty you're in, the more help that we can give to the more people that we can give, the better and the more valuable these webinars are going to be. So thank you to everybody who's already grabbed those links and put them out in groups. I've already seen them in a couple of Facebook groups, which is fantastic. Please do take the opportunity to get people on board. So what is the plan for today then? So we're going to do a quick overview of the MSRA exam. I'm sure you guys know the key points about the MSRA, but we will do that very quickly. And then we're going to very quickly talk about the key dates as well and the key changes to MSRA this round than from previous rounds. We're then going to jump into questions, because that's what this webinar is all about, teaching you common challenges, common mistakes, things that people typically do in an MSRA exam without even sometimes realizing what they're doing. And as you know, every single mark counts in this exam. We'll look at technique in a big way, particularly in the SJT side of things. Technique can make or break, really. You can know everything about everything, but if your technique is poor, you can leave a lot of marks on the table when it comes to MSRA. Well, hopefully by the end of this webinar, boost your confidence in a big way. I know a lot of people are starting to stress a little bit now that dates have come out. It kind of makes it a bit more real, and people are saying, look, I'm really stressed, not enough time. We're going to boost your confidence by the end of this for sure and put you on the right track. Welcome to everybody who's just joined us in the last minute or so. Great to see you guys on board. Thank you to everybody who has shared links and got as many people in as we can. Right. Bear with me 1 second. Fantastic. Okay, great. And as you can see, there's a coupon that will be coming out later on. We'll talk a bit about what's in that package a little bit in a few slides' time. So what is MSRA in brief then? So we're going to talk about that first off. Then we're going to do 3 clinical questions, 2 SJT questions. Then we're going to give the coupons and look at the resources. Then 2 more clinical, 2 more SJT, look at some key takeaways, and then talk about the plan for the next 6 weeks. That is if we're doing January, of course. If we're doing February, then you have a little bit longer. We'll give you a plan for that as well. So that's a brief overview of what we're going to be doing today. Welcome if it's your very first time on with us. In fact, guys, put an X in the chat if this is your first ever Arora webinar. Just put an X in the chat. Let's just see who is brand new to us today for the very first time. I'm Dr. Arora from Arora Medical Education, Portfolio GP. Very proud to be a fellow in the Royal College of GPs. Loads of previous educational roles. Education is my 24/7, 365 passion. I used to write questions for the MSRA exams, so I'm very used to the type of questions that you guys are going to be coming up against in a month or so's time. Used to be an examiner for the GMC, did a lot of work around GP training in various aspects of the GP training program. And hopefully, as you guys know, we do a lot of work around prepping you guys for MSRA, PLAB, UK Malay, GP trainee exams, and many others as well. So hopefully it's not the first time we've come across you. There are a lot of X's in the chat, so welcome to everybody who's on their first ever Arora webinar. Thank you so much, firstly, for giving up your evening and your time. These webinars don't work unless you guys join, so we really appreciate that. And welcome to all of you who are saying that you've been many, many times before. Yeah, I can recognize some names from the PLAB 2 world. I can recognize some names from even PLAB 1 days, actually. Gosh, good to see you guys progressing well in your career. So welcome back to everybody who, whether you're new or whether you've been with us before. So this is what's coming up, guys. A lot of you guys, there's been a couple of comments already saying, what is the coupon? The coupon is not coming yet. The coupon is coming later on in the webinar because there are only 15 coupons available. We very rarely give 15% off our packages, but we've got 15% off our MSRA Ultimate package today, basically our most comprehensive package for MSRA, focusing on both exams and also focusing on knowledge plus technique. There's a whole bunch of things, a 2-day live grammar course, video courses which are fully chapterized, flashcards, we've got audiobooks so you can save time when you're traveling, for example, 2 sets of question banks, a clinical and an SJT question bank, and a whole bunch of MSRA mocks as well. So that is the ultimate package that normally, when you add it all up, comes to around £800. The standard website price is 347. When you use that 15% coupon today, it is literally nearly a third of the price, 295, for all of this material, the live course, and everything that comes with getting you a high score in MSRA. And this comes with a 6-month subscription. So you have plenty of time to get through it, whether you're doing the exam in January, in February, or even later in 2025. So the link has gone in the chat if you want to have a bit of a browse and see what that's all about. There's all sorts of samples and things on that website page. And the coupon, I promise, is coming later on in the webinar, 15% off, 15 uses of that coupon. So the first 15 uses get the coupon to use. Okay, let's just get a bit of an idea on the spread of when you are all taking the MSRA. So please put in the chat, when are you taking it? Jan, Feb, or later on in 2025? Let's get a bit of an idea what the spread is on the webinar. So 100% of you are either doing it in Jan or Feb. So far, no one has said they're doing it later, say September 2025. So all of you, hopefully, are in the peak of your preparation, or maybe this is the start of your preparation. Actually, just put an X in the chat if this is the start of your MSRA preparation, this very webinar. Put an X in the chat if this is the beginning. Yeah, loads of you, which is fair enough. You know what? When you get the dates come out, that's when it really kicks in. That's when you start to feel, okay, I need to do something about this now. It's not just in the distance now, it's coming. So I can see a lot of you guys are just about starting today. Some of you guys said peak, which is great. Love that. You're ahead of the game. Right, let's very quickly talk about some of the MSRA basics, and I'm sure you guys know this. This is not what this webinar is all about. We have videos all over the place talking about this, but let's quickly go through what it is. So it's part of several different recruitment processes. So whether you're applying for GP, Psych, ONG, CST, anesthetics, ophthalmology, radiology, you all do the same exam, but different specialties use the exam score in different ways. So GP and psychiatry, it's all about MSRA. So you have nothing else to differentiate you from somebody else. You have to score well in MSRA, whereas in other specialties, think radiology, think CST, it's almost used as a screener. So you kind of, if you get through MSRA, then you move into the next round. So it's not worth the whole application process, but different specialties use it in different ways, but it is the same exam regardless of what you're applying for. 2 different papers. One is your clinical problem solving paper, 90 questions in 75 minutes. It's quite a push. We'll kind of mimic those numbers and times today when we do our questions, and then our professional dilemma question, 50 professional dilemma paper, sorry, SJT questions, 50 SJTs in 95 minutes. This is so heavily technique based, and we'll talk about this later on in the webinar. And everything is based on the national MSRA blueprint, and all of our courses, resources, links, etc., are all based on that same blueprint. So we'll talk a bit about what you need to know a little bit later on in the webinar. Now, this came out obviously yesterday. This has thrown a lot of people because they're generally every year, if you don't know, generally every year, everyone does the MSRA in the first. Guys, someone said I'm talking too fast. Give me some feedback, guys. Let me know. Do I need to slow down? Is the pace okay? Just give me a quick yes or no. Let me know where I am and I will adjust accordingly. Okay, it's fine. Pace is okay. It's good. It's fine. It's okay. Keep going like this. Great. So I'm really sorry. I'm really, really sorry. I'm going to keep going as I am because I've got lots to get through. I'd rather go quicker and get more in. This will eventually be on YouTube at some point, so you can watch this back and you can slow it down if you like. Right. So the two sittings then. So like we said, traditionally, there's a sitting at the beginning of January and everyone does it and that's it, done and dusted. Whereas now, because there are so many people doing the MSRA, they've had to split it. And that just gives you an idea about how crazy the competition is when it comes to MSRA and how every single mark counts. So sitting one is the traditional timing, 2nd to the 13th of January. If you're applying for any specialty except for GP alone or psychiatry alone, then you will do the exam in January, 2nd to the 13th of January, which is your typical time period. That's around 6 weeks away. That's why we set this webinar. We always do a 6-week booster webinar. It was based on this date. If you are doing either GP alone or either psychiatry alone, then you have to wait a little bit, 17th to the 28th of February. So you can see that as a good thing or a bad thing, depending on how you see the world, but you've got a little bit more time to prepare. Now, if you are applying for, say, GP and for CST or radiology, then you will do the exam in January, even though you're also applying for GP or psychiatry. So it all depends on whether you're doing something apart from GP and psychiatry. And if the answer is yes, then you are going to be doing it in the January sitting. Great. Okay, hopefully that makes sense. I'm sure all of you have heard about this. We've had videos all over social media talking about this, so I'm sure you're aware of your own date. Right, as people join us, firstly, welcome to everyone who's joined us. Another nearly 100 has joined in the last 30, 40 minutes, last 30, 40 seconds even. That link must have gone flying out somewhere. Welcome, thank you guys. We've just literally started. We've just run through what the exam is. If you have any questions, please do drop them in the chat. Like I said, Dr. Pooja is also on the webinar and she's already starting to answer those queries and questions that people are starting to throw in. Right, in one word, guys, before we get on to the first questions, what's the vibe? How are you feeling? Give me one word about what you're feeling about this exam. Anxious, terrified, petrified, overwhelmed, nervous, excited, love it. Confident, very good. Tricky, stressed, worried, nervous, anxious, no time, too much, don't know where to start. Happy, okay, overwhelmed, worried, opportunity, love that, scared, anxious. Yeah, look, the reason we do this is just to show you that if you are feeling nervous, tense, anxious, worried, scared, all of those things that are flying in the chat right now, you're not the only one. That's the first reason we do it, to show you that everybody else is pretty much feeling the same thing, or at some point will feel the same thing, because it is a high stress exam, high pressure exam. But just to say that everybody should be feeling like this, to be honest, at this stage, because it is a high pressure exam, and the pressure of knowing that you need to do well is what's going to be the difference between how much you achieve in the next 6 weeks or the next 2 months, depending on when you do the exam. Okay, so you need to have that stress, you need to have the anxiety. What brings the anxiety down? It's not doing more and more and more work, it's not doing more and more and more questions, it's not doing more and more and more reading, because you'll never feel like you know everything about everything, but it's the principles, the technique, understanding what are you doing multiple times that's getting questions wrong, turning those things around, and knowing that when I walk into that exam, I have cracked every bit of technique that I typically have been doing in the last 2 months, and I've sorted them all out. That gives you a whole bunch of confidence. Knowing everything about everything and doing 1,000 questions a day does not lead to more confidence. Okay, so when we teach for MSRA, yes, we teach you a lot of knowledge. Yes, we get through all the core stuff that you need to know, but we spend a lot of time getting your technique right, because that makes a big difference. A few of you are saying, is there going to be a September exam? Probably yes, because every year there's a September exam and there is a January exam. Okay, another 50 or so have joined us. Welcome. Let's get some yeses in the chat, guys. Are you ready to go? Are you ready for question one? Have you got your thinking brains on? If I get enough yeses, then we will go. Fantastic. Loads of yeses flying in with exclamation marks. That's a good sign. Right, I'm just going to get the time on the chat. So the way these webinars works then, so we're going to put the question on the screen. We're going to start with 3 clinical questions first. So I'm going to put the question on the screen. I'm going to get a timer out and mimic the same time that you're going to get in the exam. The moment you get your answer, guys, put it in the chat. Okay, the chat is hidden because any minute now it's going to go crazy with answers. So we can see all the answers, but don't worry, you can't see everybody's answers. So don't worry, we can see what you're writing. Write your answer. I want to see 2 things. Number 1, yes, of course, how many got it right or wrong, because that's important. But I also want to see how quickly are the answers coming in, and how does that link with whether you're getting it right or wrong, because that's where we start to learn a lot about technique and make a difference with these small changes. So let me just get the timer ready to go. Okay, lots of yeses in the chat. I'm going to go silent in a second. First question is coming up. have a think, and put your answer in the chat when you're good to go. Let's go. Answers flying in. And if you can see that, that's the time. That's the time. It goes fast. Put something down, guys, if you can. Don't worry, no one can see what you're writing. Don't worry if you get it right, wrong, doesn't really matter. Just put something down. Right, so every single answer has come at least once. A's, B's, C's, D's, E's. The most common answers that I can see are probably A. There's quite a few E's. There's a lot of B's coming in as well. Actually, there's a lot of every single answer. So pretty much everyone is coming. Thank you guys for putting something in. Someone's written A, B, C, D, E, which is impressive. There's only one right answer, guys. There's only one right answer. It's not a ranking question yet. That's coming up a little bit later. But yeah, fantastic. Thank you for having a go. Right, so what is the right answer? The answer is E. Well done if you got E. Now, there's a lot of technique in this question, and there's a lot of knowledge as well, and both can get you. And interestingly, the first right answer was the 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. The 25th answer was the first right answer. Now, that says a lot straight away to me about what you're doing when you see a question. That means you're looking at a question, you're looking at buzzwords, you're flicking down, you're seeing something that sounds right, you're putting it down, and you're moving on. This is going to lose you marks, okay? When you've got time, you need to take the time. Some questions need a bit more time than others, but if you go in and give your kind of first gut instinct answer, you're going to get a lot of questions wrong, even though you might have just read about emergency contraception literally 2 hours ago. Okay, it's not only knowledge that matters. So let's break this down. A patient comes to see you to discuss emergency contraception, pretty standard thing. Which of the below statements is most accurate when it comes to the 3 available options? Now, the first thing that I've highlighted here is most accurate. Now, when you see a double word like this, the most beneficial thing you can do for your own brain is to make it a single word. Essentially, this is true, isn't it? So you want to say which one of these is true. You want your brain to start going down, is A true? Is B true? Is C true? Is D true? Is E true? If you keep it as a double word, then you're thinking, is A the most accurate? Is B the most accurate? Is C the most accurate? Is D the most accurate? Can you see how straight away that double word and keeping it as a double word puts extra stress on your brain? And it means you have to work harder as you go down the link. So if you ever see a double word, change it to a single word, because pretty much any question is asking which is true and or false. It's not going to say which is true or false. It's going to say it in a different way, but you want your brain just to know that I'm just looking for the true or the false. Okay, so first thing from a technique point of view. Levonorgestrel treatment is taken as 2 separate tablets. Lots of you put A. Now, I don't know that's because whether you just forgot or whether you didn't know or whether you thought, okay, 10 years ago they did, so maybe it does still, or maybe where you are, it is taken as 2 separate tablets. I don't know why a lot of you put A, but it's definitely not 2 separate tablets. It's a single tablet. And hopefully when you think through a calm mind, you realize that that cannot be true. There is not 2 tablets. It's a single tablet that you take. And we'll go through all of this in a second. B, a lot of you guys put B. Ulipristal 30 can be taken 130 hours after the event with good effect. Now, I tell you now, a lot of the people who put B stopped reading after Ulipristal 30 milligrams because probably you thought that the 30 was the bit that was being tested. Yep, it is 30. I remember reading 30. True, true, true. So you've already decided the statement's true because the first part of it's true. So you almost read over the fact that the second part is not true. Put an X in the chat, actually. If you put B and you didn't really clock onto the 130 hours because you focused probably subconsciously on the dose of the medication, put an X in the chat if you did that. A lot of X's coming in. This happens because of technique. It's not because you don't know that ulipristal is a 120-hour limit, 5-day limit. It's not that you don't know that. It's that your brain has already decided this is true, and it just kind of makes the rest of it true. Very important to pick this up, because if you don't, you're going to get lots of questions wrong in the same way. That's why these webinars are so important. Levonorgestrel works by decreasing ovulation, not increasing. There's people who put C in the answer. I know that you know this is not true, But you've just read levonorgestrel, ovulation. Yeah, I remember it affects ovulation. True. No, it doesn't. Yeah, it's the other way around, but your brain can make it sound right. Copper coil should be removed latest 1 month after insertion. A lot of D's given. The whole benefit of a copper coil, guys, is that you can leave it in for long-term contraception, isn't it? That's the whole point. So why would you put it in for emergency contraception and then take it out a month later? What would be the benefit of that? So a lot of people use a copper coil because it can stay in for a long time, 5 years, 10 years, depending on what the local protocols are. E is not true. Ulipristal can be used more. Oops, sorry. Ulipristal is true. Sorry. False, 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 false. True. Ulipristal can be used more than once in a cycle. Now, in the past, this was different. In the past, it used to be that levonorgestrel can be used more than once in a cycle, but ulipristal should not be used more than once in a cycle. But the latest DFSRH guidance is that you can use both levonorgestrel and ulipristal more than once in a cycle. Why have I highlighted C, this word can? Because that's a soft word. When you see soft words like can, may, these are much more likely to be true statements than what we call hard words. Always, never. So your brain should look out for hard words because they're very unlikely to be true in medicine. Whereas you should also look out for soft words. Can, may are much more likely to be true than others. Not always, but if you're down to 50-50, then these little things can really make a difference. And that word can sometimes help. Okay, so ulipristal can be used more than one in a cycle. That is recent-ish changes in the guidance. So let's quickly go through a few key things about the three main types then. So levonorgestrel, 1.5 milligram, single tablet taken stat, licensed up to 72 hours, ineffective after 96. There could have easily been a statement here which says you can only use levonorgestrel up to 72 hours. That's not true. You can use it up to 96. It's licensed up to 96. And so it's licensed up to 72, but it can be effective still to some extent up to 96. So small words can make a big difference, but that wasn't in this question, just to be aware. Can start the COCP or the POP immediately. That's one of the benefits of taking levonorgestrel. You can start regular contraception literally the same time or straight afterwards, and it can be used more than once in the same cycle. Ulipristal, 30 milligrams, can be taken up to 120 hours, after unprotected intercourse. So that's 5 days, as opposed to the license of 3 days for levonorgestrel. It's actually more effective than levonorgestrel when it comes down to the numbers. So just bear that in mind. It is more effective than levonorgestrel. Not as effective as the IUD. The IUD is the most effective option, but this is more effective than levonorgestrel. And you can usually only start the COCP or the POP 5 days after. So that's a key difference. With levonorgestrel, you can start it straight away. With a COCP or a POP, you can start it only 5 days afterwards. There might be a few individual decisions to do it differently, but that's the general advice. And again, like we said in the question, it can be used more than once in the same cycle. That's a fairly recent change. That wasn't there probably, I think, a year ago. It changed about a year ago. Then you have the copper IUD, can be used again up to 5 days after UPSI, so 120 hours. The copper is toxic to the sperm and the ovum. That's how it works, basically. And like we said, one of the key benefits of a copper IUD is it can be left in place for ongoing contraception. Remember, if it says IUS, that is not an option. IUS is a hormonal intrauterine system, something like Mirena or Kylena or something like that. That is not used for emergency contraception, but an IUD, an intrauterine device, that's a copper IUD coil. That's different. So make sure you know your IUS versus IUD because it's a common area that people often struggle with. Now, one question in, I want you to put an X if you learned something about medicine and a Y if you learned something about technique, and an X and Y together if you learned something about both. Let's just see if we got off to a good start. X if you learned something about medicine, Y about technique, X, Y if you learned something about both. Good. Lots and lots of X's and Y's. And that's a great example of you could have read emergency contraception, like we said, an hour before this webinar and thought, yep, got it, clocked it, but you might have got the question wrong. And that's how important the combination of these two things are. And when we teach for MSRA, it's this focus that we do because this, to be honest, makes a difference in getting a job or not a job or getting in one round to the next round. These things make a difference. So I'm glad that you've picked some of that up already. Right, let's go into question number 2. I'm going to go silent again. 50 seconds on the clock. Let's go. 5 seconds, guys. Put something down. That is time. That is time. Right. This is a very important question by the looks of it. I'm telling you now, there are probably around 10% of you who got this question right. Max. Max. And I'm telling you, I'm going to do this again to show what's happening in your brains. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. The first 17 answers were D, and many, many others beyond that as well. Now, why is this as important? Okay, this is not med school finals anymore. Okay, this is not PLAB 1 anymore. They're not looking to see, do you know the most general, most common standard treatment for cellulitis? Now they're looking to see, right, you're applying for specialty training. Let's see if you know the difference between what's standard and what's something that I need to know on a ward as a more senior doctor who maybe come to for advice. Okay, this is now guidance. Guidance is not D. Standard treatment is D, and your brain tells you D because you've always thought about D when it comes to cellulitis, and your reflex is to put D. It's not D. The answer is A. So well done for that. Probably 5 to 10% of you who got this right. 1 or 2 words makes a difference, guys. Right? Someone said, "Do you get a BNF in the exam?" No, you don't get a BNF in the exam. It's all got to be coming out of here. Okay. So 32-year-old gentleman with mild facial cellulitis. We started in around his nose. Which of the following treatments is most appropriate according to NICE guidance? Definitely not flucloxacillin. Put an X in the chat if you were trying to work out, is it B or D? Is it B or D? What's the right dose? Is it B or D? Just put an X in the chat if that was your main decision in this question. Loads of you saying X, which is fine. I would have done the same when I started preparing for MSRA. Fluclox is not what you use in facial cellulitis. When it comes to cellulitis, there are 3 things you need to look for. Number 1, is it general? Number 2, is it around the face? Number 3, is it cellulitis with lymphedema? There are 3 very different treatments, and you need to know the difference between the 2. What you hopefully should have been trying to remember is, I know it's coamoxiclav, but is it A or is it C? That's hopefully what you were coming down to, and then it's a knowledge game. Then it's a knowledge game, okay? But you just need to make sure you're ahead of the standard reflex thinking, which is, oh, cellulitis, forever in my whole life, I've always used flucloxacillin. Makes a difference, right? Let's break it down then. So what is the general management for cellulitis? We all know these common things. We all know about rest, elevation, analgesia. We all know to mark around the area to make sure it's not spreading and getting worse. But what about the antibiotics? This is for adults. General, anything apart from face, think about flucloxacillin. 500 to 1,000, 5 to 7 days. If you can't take Fluclox, clarithromycin, or doxycycline. Easy. That's what your brain was screaming out to you. Next, if it's near the eyes or the nose, cellulitis near the eyes or the nose, it is not Fluclox, it is coamoxiclav. It's a 7-day course, 3 times a day. It's coamoxiclav. Now, maybe they won't expect you to know the dose. We pushed you, but at least you need to know the right antibiotic, because as I don't know, an ST1 in whatever ward you're on, you're going to see cellulitis. And you just need to know the difference as to what the guidance says. Now, hopefully in real life, there's trust protocols and you can check all of this as a BNF. But in the exam, they're going to expect it's all out of here. So remember that, take that away today. General is Fluclox, face, eyes or nose is coamoxiclav. And then sometimes there's a different antibiotic regime for if you have cellulitis plus lymphedema as well. But that's probably taken a bit too far. But that's the third thing where you think about Fluclox plus amoxicillin. But I just think this one is the main one to take away. And obviously, if it's an inpatient and it's a severe infection, then there are different options: IV Fluclox, IV Coamox, plus IV XYZ. And then if you're thinking MRSA, then maybe vancomycin, teicoplanin. I'm sure you guys have prescribed this multiple times in hospital settings, but just get these basic things right, because cellulitis is one of those conditions that they're going to say, you know what, we should test an MSRA because it's one of those conditions. It doesn't matter what specialty you're doing, you're going to see cellulitis. And we want to know that you can make the right decision. It's not some kind of very kind of high level tertiary condition that you're only going to see if you're in neurology, for example. They're going to test you on common conditions that you might see across the board, whether you're in GP, whether you're sitting in a ward, whether you're doing surgical training, whatever it might be. Cellulitis is just one of those classics. Okay. Put an X if you learned something. Knowledge-wise in this question, there wasn't much technique here, but knowledge, put an X. Let's just make sure we're still putting things into your brain. Good, excellent. Nice to hear. Nice to hear. Okay, right. Let's move into question number 3. Take a guess, guys, if you're not sure. 5 seconds. Okay, we're done. We're done. Well done to everybody put an answer. Again, this is going to surprise a few of you guys. Not many of you got this one right either. Common answers were A, common answers were C. Well done to the probably 20% of you, 15 to 20%, who put B. Temporal arteritis is one of those classic exam questions. Doesn't matter what exam you're doing, temporal arteritis is just one of those questions that comes up all the time. Now, you can know everything in the world about temporal arteritis, the causative reasons, the links, the associations, the complications, etc. But the guidelines are pretty clear in terms of what you should be doing and how you should be managing early temporal arteritis if you are an ST1 sitting in, I don't know, whatever place that you're sitting in. Now, when you get temporal arteritis, we all know it's prednisolone, right? So it's not going to give you a question which says, is it prednisolone versus aspirin versus something else? No, we all know it's prednisolone, and I'll assume that you know it's prednisolone. We all also know that it's fairly high dose prednisolone when you think about temporal arteritis. But what is the most important feature of a question that will change the whole game? It is changes in vision. Now, put an X in the comment if that wasn't the most important thing that you read in that question. Changes in vision. Put an X if that wasn't the most important thing that you thought about in that question. Loads of X's, which is fine. That's why you do these webinars. Now, whether you have change in vision or not changes the game, okay, in terms of what dose you give of prednisolone. So let's quickly break this down. If somebody does not have eye symptoms, then your dose of prednisolone is 40 to 60 milligrams. Now, the only option here, therefore, because they have no changes in vision, is option B. Now, just put another X in the chat. If you just looked at a 50 and thought, nah, that just sounds odd. Like I've never thought of 50 pred before. Sounds odd, and therefore it can't be right. Put an X in the chat. Now, lots of you put an X in the chat, which is fine. It is a random dose, but there's no 40, there's no 60, and the dose is, and the guidance is pretty clear. Anything between 40 and 60 is what you should be given with no eye symptoms. Okay. Admit if possible. Admit if possible. Urgent review if not, usually within a couple of days max. This could be rheumatology, it could be ophthalmology, it could be medics, doesn't really matter. But ideally admit, urgent review, some leeway there if they haven't got any eye symptoms. With eye symptoms, much higher dose, 60 to 100 milligrams, definitely admit on the same day, may need IV steroids. Okay, big difference. Someone's saying, with eye symptoms, don't we need to give IV steroids for 3 days? Don't worry about that. This is not what this question is talking about. It's about you're seeing them first up, first person. What do I treat with? Do I admit? Do I not? What dose? That's what this question is about. Okay. Do we need to recall the dosage and management plans? Yeah, 100%. This is emergency acute dosage. Of course, you're going to have to know this. Now, you're not going to have to know what are the protocols for day 7 steroids in temporal arteritis. Why would they expect you to do that? You've got teams around to help you, etc. But when you're seeing somebody at the cold phase, they need you to know that you know the core urgent emergency guidelines. So this is something standard that can easily come up in an exam like this, and it's going to be a good differentiator because a lot of people just think, yeah, I know that in temporal arteritis you use high-dose steroids, but what? What does the guidance say? What's the key differentiator? What should I look out for in the exam? This kind of thing is the most important thing. Sometimes just a quick word about antiplatelets. It used to be in the past that you also give aspirin for everybody with temple arteritis. Now the guidance has changed. It kind of said do on a case-by-case basis, rheumatology involvement, ophthalmology involvement. It's not always aspirin 75. It might be in some, but I just wanted to put that there because some people still remember it as being you need to give aspirin to everybody, whereas that's not the case anymore. Yeah. Good. We've only done 3 clinical questions. On our live MSRA day, by the way, there's 1 day SJT, 1 day clinical. We do, I think, 50 questions like this clinically, going through all the key guidelines. But this is a couple of things that we talk about in terms of technique and how it makes a difference. We've already talked about this one, convert double words. If you see a double word, which one is most accurate, most inappropriate, least likely, change it to a single word, take the pressure off your brain. We miss small words as clinicians in questions. We just miss them. Do, don't, are, aren't, not, usually, commonly. The small words are the words that change the game, not the big words. Your brain goes toward the big words. You look at the condition, you look at the drug, you look at the, whatever it is, but we miss the small words. And really commonly the small words change the game. We haven't shown an example of this yet, but we will. Soft versus hard words, we talked about this earlier, didn't we? So the softer words like can and may and sometimes are the high value words, because even if it's 1 in a million, that's a true statement. So soft words are very often true. Hard words, 100%ers, are very rarely true, because in medicine, let's face it, very little is 100%. So look out for those soft words versus hard words. It can make a difference. And make sure every single part of the statement fits. Take you back to that question 2, where we looked at ulipristal 30. We're thinking true, 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 true. But later on, it became false, 130 hours. Make sure every single part of the statement is true. Question coming in, do we need to memorize exact doses for MSRA? Urgent cases, emergency cases? Yes. Every single dose of every single drug? No. Emergency and urgent dose drugs? Yes, they'll expect you to know that, because that is important from a safety point of view. But do I need to learn the exact dose of routine use of, I don't know, alendronic acid for osteoporosis? No, probably no. Do I need to know temple arteritis doses? Yes. So that's kind of how you gauge it. Urgent, emergency doses, yes, you do need to know. And we cover all of them. If you've got the packages, we teach you all the doses that you need to know, because there's not that many, but you do need to make sure that you know them. Before we move into SJTs, who is using the planners, the free planners? Put an X in the comment if you're using the free planners, and put an N in the comment if you've never heard of these free planners. Let's just get a bit of an idea. Loads of X's, that is great. Great. Loads and loads and loads of X's. Quite a few N's as well. There'll be a link going in the chat very shortly for these free planners. They're completely free. You go to the website, you can look when you're doing the exam. So for example, we have a 30-day planner, we have a 60-day planner, we have a 90-day planner, we have a 120-day, we have a 150, 180. You just print it, stick it off. It'll tell you day 1, day 2, day 3, what to cover. If you've got the packages, it'll even tell you, what audiobook to, what chapter to listen to, which card to read, etc. So have a look on the planners and see if they can still help you even in this last section. Right, we're going to go on to SJTs. Same thing. Question goes up on the chart. I'm going to give you slightly longer for these questions, and let's see how you do. Ready? Let's go. Twenty seconds. Okay, guys, jot something down. Okay, that is time. That is time. Well done to everybody who put an answer. We'll go through the answers in a second. Now, the first thing to remember about SJTs is that technique is much more important here than clinical, probably. Don't always go with what your gut instinct tells you straight away, because our gut instinct doesn't always look at things in a certain way. Use gut instinct, but don't just rely on, well, it's obvious it's gut instinct. You have to think a little bit. Some of you guys have put 3 options here. Look at the question that you're doing. You're doing a ranking question here. It's not a choose 3 from. So here, every single answer should be put down. Every single answer needs to be put. You need to rank it from top to bottom. All of them need to be ranked. It's not that you need to select 3 of the best options. That's a different type of question, which we'll talk about in a second. Now, I'm not too worried about whether you got the exact answer or not. That's not what this webinar is about. It's about, how do I have a process? Do I have an approach? Do I know what I'm trying to do in an SJT question? So let's try and break it down from that angle. Now, the suggested answer, and there were some of these that matched this, so well done, but there were lots that weren't, lots that were similar but not quite, is CBAED. Now let's try and work out why and what are the kind of things you should be doing to try and get to something like the suggested answer. Okay, so you're an F2 doctor on orthopedic ward. Your team has just seen an elderly Spanish man on the busy ward round who understands limited English. Your registrar has gained written consent from him for his hip operation scheduled for 2 days' time. So look, 2 days' time, it's a bit of time, yes. It's not like he's going in now. One of the nurses quietly says to you that she suspects the patient was just nodding politely and understood very little. We don't know this, it's just a suspicion. She says she does not want to undermine the registrar. You know his daughter visits daily and always translates if she is present. Do you rank the following actions in order from the most appropriate to the least appropriate? Now, the first thing I want to say about these questions is get your mindset right in the first place. You're doing a ranking question. So your mindset needs to be thinking, or. Would I do this, or this, or this, or this, or this? In the other type of question, you have a different mindset, and. And won't work for you in this, or only will work for you in ranking. So you start with 5 options on a very basic level. You start with 5 options. You think this is the best one, and you throw it out the window. You're down to 4. Out of these 4, would I do this, or this, or this, or this? You choose the best one. You throw out the window. Then you're down to 3. Now, they're probably not 3 very good options, but you still need to think, if I had to choose one, would I do this, or this, or this, and why? Throw it out the window. Down to 2, probably 2 rubbish options, but you have to think, there is one reason why one is better than the other. What is the reason, and therefore which one do I choose? Is it this or this? And you're left with the last one. So you have to use an or mindset, and once you've chosen an answer, it's gone. Forget about it. You're starting afresh again. This is different to the next set of questions we'll talk about, okay? Now, a couple of questions coming in, confidentiality, etc. We'll go through all of these. First thing is get the right mindset. The second thing that we teach a lot is the 4 C's. The 4 C's that help you determine, when you start to determine orders. We'll talk about the 4 C's in a second. And the third thing we talk about is, what's the goal of this situation? What am I trying to achieve? And which things get that done? I might have to bypass a few things that are not great, but what is the end goal, and which options get me closest to that goal first? So you've got to think, what sounds good versus what sounds good now? What action is going to make me get closer to the end goal? And once you get these things in your mind and start to get used to these things, these become quite easy. So let's break it down. C, a lot of you put C first, not all of you, but a lot of you. Speak to the registrar privately at the end of the ward round about concerns. What kind of things makes you think this is good? Number 1, privately. Okay, so you're not getting people involved. It's not in front of others. It's not in front of the patient. They're not going to think what's going on, why they're having an argument. You're not going to undermine the registrar. You're not going to talk in front of other people. And it says that it's scheduled for 2 days' time. So there's nothing immediate that you need to do right now, because it's not like he's going to theatre right now where you might need to do it now. So all these things into account mean that this is the best answer, because your aim is to flag this up. You can't let it go. You have to flag it up somehow, but you've chosen the most tactful way of doing it. Next, so you throw this out the window. Forget this, it's gone. Now you've got to think, out of these 4, would I do this, or this, or this, or this? B, address your registrar in front of the patient about these concerns, presuming the patient does not understand. Now, this is good in a way because you actually make sure you've done something about the problem. You know you've talked about the problem. You've not let it to chance. You've not let it go. You've brought it up to the right person, but it's not as good because you've done it in front of the patient. That can undermine the patient. He maybe can't even speak English. He's probably wondering what they're talking about. I'm getting a bit scared now. Can you see how that can't be as good as C? A, because you're not under time pressure. You've got 2 days. And B, because it's more respectful for the registrar, your colleague, and also the patient in front of you. But your goal is to bring it up, and you've done that. So it's still fairly high. A always becomes a bit of a discussion point. Call the patient's daughter directly to alert her what's happened. Now, some of you would put automatically A to the bottom because your brain is telling you, oh, confidentiality, big red flag, bottom. Can't break confidentiality. I've learned this forever, can't do it. How many of you read that confidentiality thing and thought, this is terrible, and you just stopped at that? Can't break confidentiality, it's got to be the bottom. Put an X in the comment if that thought crossed your mind when you read about that statement. Lots of X's. And I'm not blaming you. This is what you do. We've been brought up to learn that confidentiality is sacrosanct. However, let's look at the other two options. Because remember, you're down to 3 now, and you've got to think, would I do this or this or this? What's the goal? The goal is to make sure this person doesn't go into an operation without signing, knowing what he's signing. Let's look at E. Encourage the nurse to speak up and carry on with your award round tasks. Does that sound dodgy now? Yeah, you know what, nurse? I think you're right. I think you should have a chat with them. Yeah, you're going to do that? All right, cool. Carry on. She may not say anything. This guy may end up going to an operation without having consented properly. Why? Because you've taken it to chance. What's the end goal? The end goal is that we make sure this person has been correctly and appropriately consented. Encouraging somebody to do it and then forgetting about it is pretty risky. D, ignore the nurse's comment. After all, the patient's daughter could always relay her concerns when she visits later. This is even worse. You're not even doing anything about it. At least with E, you're putting some level of input in that gives it a higher chance of actually doing the job. Now look at A. Call the patient's daughter directly to alert her what's happened. Why is this bad? Because you're potentially breaking confidentiality. It does say a lot about the fact she comes in daily and always translates, so you can presume a little bit, but you're still breaking confidentiality potentially. However, it's got to be better than E and it's got to be better than D because it has less chance of this person having an operation without knowing what he signed. So your end goal has to trump other things sometimes. And that's why when we talk about what sounds good versus what sounds good now is much more important than just your gut instinct, thinking confidentiality. No, don't care. Can't be good. Bottom of the pile. Put an X in the comment if that makes a little bit of sense. Just put an, you have to agree with me fully. Does that make sense as to an approach? Good. What I really want you to start doing with SJTs is thinking, what's my end goal? What am I trying to achieve? And then start thinking which statements go closest to that. Not let me just rely on my gut instinct and basic knowledge and general knowledge and hope it all comes out. Because general knowledge can overshadow your end goal, okay? So that's a really important thing to pick up. And you're right to question, is confidentiality a bad thing? It is, but you've got to look at it on the basis of what else do I have? And how does this impact the problem? And that can make a big difference, okay? So that's why it's suggested as CBAED. Now, you don't have to get exactly all of this, remember, to get, it's not like right or wrong. You don't get 1 mark or 0. It's all statistically graded. So you get rewarded for certain things in certain order. That's just how MSRA is marked. We have the same in our own marks. It's not just a red or green, basically. But the more you get in position, obviously, the more percentage you get, the higher overall mark you're going to get. So you want to try and get it in some rough order. You might get a couple the wrong way around. Fine. That's not going to change the game. But getting 4 out of 5 the wrong way around because you relied on gut instinct, okay, that's going to harm you in a big way. That's where technique makes a big difference. Is it a bad technique to first identify the best, then the worst, and do the or in the middle? No, it's not a bad technique at all. As long as you're clear on what the end goal is and you're thinking, you know why it's the worst option. Because if you're looking at it as worst because it sounds worst, but you haven't really thought, why is it worst? It just sounds worst, then it's not a great approach. So it comes down to, do you know what you're trying to be tested or what you're being tested on, and then how to approach it. So let's quickly break this down before we go into the next one. You've got the and or the or technique. So we talked about the or technique. This is what you use in a ranking question. We'll talk about and in a second. Then you've got the 4 C's: clinical, convenience, communication, colleague support. Now, these are not all going to be important in all SJTs, but when you get to a blank spot, when you think, I just don't know what's better here, think about using these 4 Cs. C number one, clinical. Is there anything from a patient safety point of view or a personal point of view that would put this at higher priority? Is there any clinical need to highlight something? Number two, convenience. Think about convenience to you and think about convenience to others. For example, for you, if it's saying you should delay something and stay behind and you've got teaching, but you'll miss teaching, is that convenient to you? If it's saying that you've got this job to do, but you'll stay behind, but you'll miss your train, is that convenient to you? How does that balance up with something else? Convenience to you is important. You are a clinician, you've got your own needs, you've got to wear that in mind. Doesn't mean everything, it doesn't mean that will trump everything all the time, but you need to bear that in mind. Versus convenience to others. For example, am I keeping people waiting? Patients, colleagues, for example. Do I need to be telling someone I'm being late? Is that convenient to others? Do I need to stop what I'm doing now and do this because they've been waiting longer? What's the convenient factor to others? Three, communication. Communication with patients, communication with colleagues. If, for example, you are delaying seeing a patient because there's another patient unwell, is there anything that tells me I need to communicate my delay to another patient? For example, is there any particular way I should be communicating? Someone's upset. Is there any stem or line that talks about empathy, talking about apologizing? Communication to patients is a thing to think about versus communication to colleagues. For example, my consultant has called me to come and do a COT, a CBD. I can't because I've got clinically somebody more important that I need to sort out. But should I be communicating back to my colleague or should I be leaving them hanging? Send a note, tell them I'm going to be late, apologize. These sort of things might come higher, even though they're not clinically as important as the clinical one. So communication to patient and colleagues is very important. And then colleague support. What support is available to me? For example, I'm running behind, I'm late, I've got lots of things. How can I delegate? How can I ask for help? How can I go to my senior? When do I talk to my registrar? When do I communicate things to my consultant? What's the communication available to me? And then also, what colleague support is needed by my colleague? If it's talking about a colleague who's struggling, a colleague who's fallen behind, a colleague who's unwell, what support is available to them that I should be thinking about as a colleague? Remember, GMC is very hard about, very good about, very on it about protecting others, mentoring others, helping others, supporting others. What do I need to do? And how can I think about those things? These 4 Cs are just nice to have in your mind for those questions that you go a little bit blank. It can just get you back on track. So try and keep them in your mind, but you're not always going to need them, but they're there in case you do. But this is important. What seems right versus what seems right now. And this will become more apparent as we do a few more questions that are coming up. I think at the clinical part, is there anything clinical from a patient point of view that I need to act on that I can't leave? Or is there anything not clinical for me, but personal safety for me? Do I need to get out of a situation? Do I feel unsafe? Is there anything worrying me for me? We'll come on to this in another question, but that's what the clinical is all about. Okay, let's try the other type of question then. This is the 3 from 8. So this is a different mindset. Let's give this one a go. Oh, before we do, Telegram group. If you've got your phone, open the QR, scan this, and join the group. Every single day we do audios, videos, MSRA related stuff every single day without fail. It's just quick little revision that can keep you ticking over. A lot of you have joined this already this evening, which is great. If you haven't, grab the QR code. There'll be a link going in the chat. It's just gone out in the chat as well. Get yourself on that group. Even if you stay on it till January and then leave, that's fine. Let us teach you every single day. Next question, let's go. Rehab, I'll mention that in a second. That's time, guys. I'll give you a few more seconds. Okay. I think this is a little bit better than the previous one. So well done. Some people find this type of question easier than the ranking question, but still there's a lot of people who haven't got this right. So let's break this down then. So firstly, well done if you got this kind of combination, D, F, and H. Let's try and work out why it's D, F, and H, and more importantly, why it's not some of the answers that you've put in the chat. And I can see why you're putting some of these answers. So you're an FYG doctor on AMU, one of your colleagues, FY2 colleagues, so it's your own level colleague, remember, that makes a difference. John appeared very slow at assessing new patients and thus sees less patients in a shift compared to the rest of the juniors. This has happened for a month, so fairly good sample size, and is causing frustration within the team who feel they are working harder than John. Choose the 3 most appropriate actions to take in this situation. So the first thing here is different mindset, okay? Here you're looking at an and mindset. You're not looking at would I do this or this or this or this or this or this or this? It's not or, it's and. Which combination of 3 things takes me furthest down the line? Which combination of 3 things together deals with this situation the best? So really you're thinking about 3 separate things that you're trying to do as a whole. Now, some of them might be quite similar, but you've got to think, okay, I can't do 2 things that are similar. That's pointless. Let me think of 3 individual actions that in totality make the best approach. Okay, so it's an and mindset, not an or mindset. So let's talk about the 3 that are considered the right ones first. Reflect in your written portfolio about how to deal sensitively with a concern about a colleague. Remember, this is not saying this doctor is unsafe. There's nothing from a patient's safety point of view. We haven't reached that point yet. So reflect in your portfolio how to deal sensitively with a concern about a colleague. Now, the GMC are very big about reflection and improving not just your clinical knowledge, but also dealing with colleagues, etc. So every time you see something about reflection, you've got to think hard about not putting it in because any situation can be reflected on. And this is a particularly difficult one because it's probably the first time in your career that you had to deal with this. Reflect. That's your own personal need from the situation. F, discuss your concerns informally with John over a team coffee meeting. Informally is important. Coffee meeting is important. You're not bringing it up on a ward round. You're not bringing it up in a place that's going to look like you're challenging him. You're doing it informally. There's less pressure around. John might be struggling. Who knows? John might tell you about all sorts of things going on with his life. John might just be unlucky and is ending up seeing the patients that are the most complex. We don't know yet, but we need to have an informal discussion with him to see is everything okay. That's why it's a good option. H, inquire about the patients that John sees and discuss if he's struggling at work. This is your kind of patient safety bit now. So we need to inquire about the patients that he's seen because if he is struggling, then could there be any patient safety issues? And therefore having a chat about the patients he sees is your clinical safety. Because if something is you find to be wrong there, it needs to be escalated. We're not in a situation yet where we think anything has been clinically unsafe. So things like going to a consultant at this stage might be 2 steps down the line. At this stage, we need to work out and see what's happening. And also discuss if he's struggling with work, because this is your colleague support thing. Maybe he is struggling. Maybe he's going through stress. Maybe he's going through burnout. Maybe he's going through some out of hospital stresses, and maybe he needs some support. So this is always a good way to do it. So the combination, number 1, I've done something to improve my ability to deal with these situations. Number 2, I've had a chat with my colleague to see what his side of the story is. And number 3, I've thought about is there any patient safety needs or any colleague needs, and I've looked into that together. That combination takes the story forward, given that A, we don't know enough about the situation yet. We don't know reasons why this is happening. Maybe he is just unlucky and seeing really, really difficult patients. Or B, is it because he's struggling and that's leading to patient safety issues, which would mean I need to do something a bit more. But we're not quite there yet. So these 3 things can help us get to that point. Right? Why is A wrong? Let's go through the ones that we've put that are not quite the best options. Provide feedback on his anonymous multidisciplinary feedback. Now, when you first read this, it sounds pretty good, doesn't it? Like it's a reasonable thing to do. But this comes down to the point of what sounds good versus what sounds good now. Now, when might this MDT feedback happen? I don't know, probably a couple of months away, number 1. Number 2, okay, you might write something. Is he even going to read it? Is he going to reflect on it? I don't know. It's too much to chance, and it's certainly not going to do anything about it now. In fact, it's going to be left to the end of the job. And if there is a real problem, patient safety or colleague needs support, I've missed the boat. Can you see how what sounds good versus what sounds good now is a completely different thought process? There are so many things that you'll read in these questions that think, you know what, that sounds pretty good, actually. Let's do that. But when you think about, is it going to influence anything at this point? Probably most of them won't. And that will steer you away from that type of answer. It's not a wrong answer. It's just not the best out of the selection that you have. Hopefully that makes sense. Can A be better than C? Okay, let's look at C. Suggest to seniors that there's an ongoing audit looking at how many patients are clerked per team member. So again, this sounds like a reasonable thing. But how long is an audit going to take? Would the seniors actually agree to doing this? Would that actually lead to me picking up a problem either with John or with the patients that John has managed? No. Or if it does, it will be too late. So therefore, it sounds good, but it's not very good now. I wouldn't say it's better or worse than A. It's just not something that's going to help at this point. Inquiring about the patients John sees, is this a discussion that takes place with John or the patients? As it got me confused. So it doesn't really say, but it's showing that you're thinking, I just need to make sure that everything has been okay with the patients that John has seen. That can be done in multiple ways. It doesn't really say, but somehow you need to get a bit of an idea, is there any patient safety concerns here? And I just see it as a more global thing rather than who do you do that with. B, alert the consultant to unfair work burden to prevent burnout within the team. So firstly, it's probably 2-3 stages away from going up to the top level consultant. Remember, you've got to choose when is appropriate to go to a consultant. Going to a consultant needs to be done without fail if there's patient safety concerns. But if you're not at that point where you know there's patient safety concerns yet, you're a bit probably, you can't go to a consultant without talking to the person first. So you've got to think, where am I in the story? What's already been done? What's the next appropriate action? Going straight to a consultant is probably a bit too far at this point, especially because we don't know whether it's just genuinely the fact that John had really long, difficult patients and complex patients. And if you go straight to a consultant, then a consultant looks at the notes and goes, well, no wonder he's taking long. He's got this patient, these patients have got 15 medical problems. Can you see how you might have jumped the gun without knowing enough information? That's why B is not an ideal situation. If I reflect on the situation in my portfolio, how will it help John? See, this is not done to help John. Option D is not to help John. Option D is for you. You have to come up with the best 3 things to handle a situation properly. You're a junior doctor. You've not dealt with these kind of situations before. Reflecting on it makes you a better doctor, and so you can learn from the situation. It's got nothing to do with John, option D. But not all your options need to be to do with John. It's about what 3 things together make the best overall approach to take this story forward. Can you see? I'm not reflecting my portfolio to help the team. Why not B? We've just been through that. It's too far. We haven't got enough information to go to a consultant yet. Consultants have got hundreds of things to think about. We can't go run into them about these types of things. We've got to figure out what's going on first, talk to the right person, check patient safety. If there's a problem with patient safety, then go to a consultant. It's too early. You can't at this stage go to a consultant when there's so many other things that you can more realistically do first. Eventually, you might need to do that, but at this point, there's not enough information to tell you to go to a consultant. Yeah? E, mention the situation in passing to the nurse in charge. See, that's one of those kind of iffy ones. Mention it. Like, how do you know anything's going to be taken? No action is going to happen. The nurse in charge is probably busy with 1,000 things. A junior doctor mentioned in this is not going to probably change anything. So you've got to think this is quite a weak statement because it doesn't do anything. There's nothing, I can't guarantee that's going to lead to anything. And therefore it's a bit of a weak thing. G, say nothing. Some people G, say nothing, but try to ensure left with seeing the more complicated, left with seeing more complicated patients instead to balance the unfair work. But you can't do this. You can't engineer who he sees because you want him, because you're spending longer, you give him more. See, that's just unfair. You can't just engineer work life like that, and that's why that's an inappropriate answer. Can you explain D again? Reflecting on your portfolio. See, any situation that you get in clinical practice, remember you can reflect on it to improve yourself as a clinician. Whether it's clinical knowledge that you want to improve, whether it's a situation that you're experiencing for the first time, In this aspect, it's about how to deal sensitively with a concern about a colleague. How do I approach this? What's the best thing to do? Reflecting is a big, big thing when it comes to GMC and building your own ability as a clinician. So that's why if ever you see reflection, as long as there are not three things that are more pressing before that, it's always going to be a good option to choose. Great. Very different mindset. Again, some of these things could have been used here. Certainly clinical. Did we have any clinical patient safety issues? No, but we need to find out if we do, and therefore what action can I do to find out? Talk to John, ask about the patients, find out. C, clinical. Communication. What's the right environment to talk to John? How should I talk to John? Who should I communicate to? When do I go up the ladder? This is all communication. This is all C number 3. Colleague support. Maybe John needs support. How do I know? I've got to find out. Talk to him. Find out if he's okay. Is he coping okay? Maybe he needs some support. Maybe he's burning out. Maybe he is stressed. Maybe he is finding it difficult. I need to be able to offer support to my colleague. How do I know that without talking to him? So can you see how these C's can really help when you're a bit stuck? Sometimes you don't need them, but sometimes you do. And this question highlights this: what seems right versus what seems right now? Because there are quite a few things in this STEM that actually sound pretty reasonable. But you've got to start training your brain to think, okay, that all sounds nice, but I'm not after nice. I'm about what's going to make the difference now. What's going to make some positive action now? What's going to change the problem now, solve the problem now? And when you think like that, a lot of things get thrown out the window because you realize actually they just sound nice. And my brain likes things that sound nice, but it doesn't mean they're the best actions at this point. Yeah. Now, we've only done 2 SJT questions so far. I've got some more on the other side, but does that make sense? Like, can you see this is an approach thing? It's a technique thing. It's about how you approach these questions in a systematic way. Is this helping so far? Can you see this actually being worth you being on, or would you rather be watching something on TV or whatever? Good, good. Lots of yeses coming through. I tell you, these simple things make a difference. And if you don't think about things like this, you're always in the dark. And if you're always in the dark, you're relying on gut instinct. And if you rely on gut instinct, you're going to leave a lot of marks on the table. I've seen it too many years, too many times. It's just the way it is. But good. I'm really glad that it's been helpful. Rah, a lot of you guys, some of you guys have said the coupon's not working. How do you know the coupon? We're not given the coupon yet. This is the coupon, okay? It's not 15% off until you put the coupon in. I think people have been trying to purchase it without the coupon. This is the coupon. If you know what you want already, pass MSRA 15. Pass MSRA 15. The link for the ultimate package is gone in the chat right now. There are 15 coupons available with 15% off tonight. When there's 15 finish, it closes. So if you know what you want, click on the link and use that coupon now. Pass MSRA 15. If you don't know what ultimate is, this is ultimate, the most comprehensive package we have for MSRA. It's a 6-month access program, so you've got plenty of time to go through it multiple times. There's no limit to going through things. There's a live course. The live course for the January exam and the February exam is the 17th and the 18th of December. 1 day is SJT, 1 day is clinical. It's a watch back course. You can watch it back until the exam if you can't make it on the day. 2 full video courses, chapterized. 1 clinical one talking about all the key guidelines, all the investigations, all the stuff that you need to know. And then 1 from an SJT point of view, 40 questions broken down. You get to do it and we explain why they're right or wrong. That's your 2 video courses. 2 audio courses, if you're busy, if you have no time in your life, if you've got lots of stuff going on, work, on-calls, family, whatever, use the audiobook. We'll teach you through audio when you're traveling, when you're at the gym, when you're running. It buys you time, it saves you time. Flashcards, we've got our clinical guideline flashcards with all the core clinical guidelines in a nice little bullet point flashcard point of view, plus SJT flashcards, all the key GMC good medical practice guidelines to help you with your SJT come in 2 different flashcard sets, digital flashcards on your screen. We've got 2 question banks, clinical question bank, SJT question bank, questions similar to what we've done today, teaching you not just the knowledge, but also the technique as well. And then we've got our full mock exams. There's 6 mock exams in total in time conditions for you to do closer to your exam once you've maybe got through all the questions in the question bank. So all of that, the package price is normally $347 on the website. It's worth close to $800, but with that coupon today, it gets it to under $300, so $295. How many SJT questions? Well, SJT questions, we have the most of any bank, 300 plus. Plenty of SJT questions, around 1,000 plus clinical, plus the mocks. Can the coupon be used for booking the grammar course? I don't think so. You could try Pass MSRA 15, but Pass MSRA 15 has been set for MSRA Ultimate. I can see the first few people have started to use it already. There are 15 available. Once they run out, they run out. Otherwise, it runs out at midnight tonight, whichever one happens first. But I can see already a few people have used it, so I can tell they're going to go pretty quickly. Okay, I'm going to get another glass of water. I'll leave this up for 2 minutes. We'll come back. On the other side of the webinar, we have 2 more clinical questions, 2 more SJT questions. We'll talk about what to do in your last 6 weeks or 2 months based on when you're doing the exam, and we'll wrap up all the key things to get you in the right place to score well in the exam. I'll see you in 2 minutes. Links have gone out in the chat if you want to use the coupon. See you soon. Guys, just jumping in back before we go into the next section, there's a lot of questions coming in. Firstly, are the question bank the same as the 7 mocks? They're separate. They're separate. There's no duplication of questions. If you've got the 14 mocks, that's different. But if you get the package, they're different. The mocks are different to the question banks. How long do you get access? 6 months. Can we extend it? Yes, you can if you need to by the end. What else have we got? When do you get access? The moment you make the purchase, you get access. So when you set up an account, you make the purchase, everything will be in your account from straight away. You can use it multiple times. How long are the video courses? The clinical video course is around 24 hours in total, 25 hours. There are 24 chapters, all based on clinical cardio, respiratory, gastro, GU, pediatrics, exactly as you're going to get in the exam, the same topics. SJT course is around, I think, 2.5 to 3 hours. Can you watch back the live course? Yes, of course you can. If you can't make the 17th and the 18th of December, those are the days of the live course, you get to watch it back until the exam, until the February exam if you're doing February. What else have we got? How hard are the questions? Challenging, like we've been doing today. There's no point doing questions and getting 100%. Like we push you, we challenge you, knowledge and technique, but you feel a lot better once you've done them. Are you on the live course? Yep, I'm there from morning to evening on both days of the live course. Is this going to be recorded? Yes, it is recording. We'll get it out on YouTube at some point. Not sure when. It'll take a bit of time to edit it, but we'll do it. Coupon's not working. It is working. We're getting people using it. Pass MSRA 15. It's not run out yet. I haven't checked actually. I'll check. Pass MSRA 15. No spaces, no gaps, nothing like that. Just put it in, press enter, and go through. If it's not working and you're worried, just purchase it full price and let us know, and we'll refund you that amount back, because I don't want you to miss out from that. Already got the gold package. Don't have access to question banks. Sent an email. Yeah, if you've got the gold package already, then we can add in anything that's been added. Did purchase ultimate. Question banks are new. Question banks are new. So if you've got ultimate package already and you haven't got the banks, send us an email and we'll add them in. Good. Okay, I think that's most of the questions. I want to move on because there's lots of stuff I still want to teach you yet, but all the common questions I think I've answered. When do the coupons run out? Midnight tonight, unless 15 coupons go. Once the 15 have gone, they've gone. Okay, fine. Great, I'm going to move on then, guys. Dr. Pooja is going to be in the chat to keep on answering certain things, but I'm going to carry on to the next part of the webinar then. So, like we said, Telegram group, please do jump in and use that. Every day we do teaching and every day we do videos and audios for MSRA. Don't forget us on social. A lot of you guys follow us on Instagram, which is great. We do lots and lots of teaching daily on Instagram, Telegram, like we said, and YouTube. Lots and lots of teaching on YouTube as well. All the links are going up as well. Okay, fine. Good. Right, back to clinical. Let's go. Next question. Off we go. Good. Answers flying in. Okay, that is time. Well done. If you got the right answer, D. Now, pediatrics has three main, what we call pediatric giants that you really need to know. Pediatric immunizations and vaccinations is one of them. The second one is pediatric development. And the third one is pediatric infections, things like measles, mumps, rubella, slap cheek syndrome, etc. So these three things are pediatric giants, and we say that you must know them for this exam: immunization, child development, and childhood infections. We definitely cover them in detail in the packages and the courses. So what's missing an element? D, missing your PCV, pneumococcal conjugate vaccine. All the others are fine. Let's quickly break down these vaccinations then. Now, this is quite hard to learn. Put an X in the chat if you find this quite difficult to learn. I certainly used to. Let's see if other people do as well. Yeah, pretty much everyone is saying X, 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 X. It is hard to learn. There are a couple of ways of trying to learn it. Some people like to learn it horizontally, so they kind of learn 2 months, 3 months, 4 months, and just learn it that way. And if you can do that, then it's fine. If you don't learn that very well, then you can try and learn it in doubles and triples. That's how I used to learn it. So I used to learn, remember, rotavirus is a double and it comes at 2 months and 3 months. I used to learn, for example, that PCV is a double and it comes at 3 months and a year. I used to learn that, for example, MenB is a triple. It comes at 2 months, 4 months, and a year. And I used to sometimes find that better than the horizontal way. But either way, it's just pretty tough. And either way, you just need to learn it for the 3 hours of the exam, basically. So what I would suggest is maybe screenshot this or write a table out and stick it on your wall and just look at it basically every day until you basically memorize it. So all you can do, unless you can use the double and the triple method, which can work for some people. Otherwise, I would just try and stick it on the wall and just read it every day. It's probably the best way to do it. Same with development milestones. Stick it on the wall, read it every day. It just helps. So let's quickly run them down. So you've got a 6-in-1 jab: diphtheria, tetanus, pertussis, polio, Haemophilus influenza B, and Hep B. That's your 6-in-1. So you get that 3 times, 2 months, 3 months, and 4 months. And then you get other things alongside it. So like we said, rotavirus comes twice. The first 2 blocks are rotavirus, and MenB comes 3 times at 2 months, at 4 months, and at a year. PCV comes in twice, so your pneumococcal conjugate vaccine. So if you go back to this question here, you can see that this is 3 months. It doesn't have the PCV there, and that's why that's the right answer here is missing an element. Then you have a gap, so 2 months, 3 months, 4 months. Then you have a break later on, end of the year. You come in with 4 more jabs. Your first MMR takes place then. Then from 2 years to 15, annually, there's a nasal flu spray, generally done at school. 3 years and 4 months, you have a DTP polio, so a 4-in-1 and your final MMR. Then there's a big gap. 12 to 13 years, HPV, human papillomavirus, comes in, usually a single dose for boys and girls. And then your last pediatric vaccination happens at 14 years of age: DT, diphtheria, tetanus, and polio. And then your 4 meningitis: A, C, W, and Y. Like I said, it can be challenging, can be tricky. Screenshot it, look at this every day, and very quickly you'll find out your own pattern to work it through. Are there coupons left? Yep, I think so. Coupons are still left. 15 definitely haven't gone yet. Next question, let's go. A bit less for this, less time to read. Another 15 seconds. Okay, let's call that time then. So well done if you put E. There's a lot of people who didn't put E, actually. Definitely less than half of you put E as a right answer. A couple of things to take away here then. So you've got least likely. So again, a lot of people would miss the word least. Just put an X very quickly in the comment if you missed the word least. Put an X in the comment if you missed the word least. Yeah, too many X's, guys. You've got to get this right because this is going to cost you marks. Okay, what do we say about small words? Our brain doesn't read small words very well, so it just misses it out altogether. So all you look at is, oh yeah, clubbing, likely, what is it? And you could choose A, B, C, or D. The moment your brain just picks up to one, yeah, I remember this, you put it down, you move on, you think I've saved some time. Least likely. Our brain does not read small words. How many of you did not put E as you read it as bronchiectasis? Put an X in the comment if you read E as bronchiectasis. Yes, lots of X's in the comment. Can you see what your brain does? Your brain reads what it wants to read. Simple as that. Your brain doesn't want to read what it doesn't like. It reads what it wants to read. And of course, bronchiolitis doesn't cause clubbing. You know that. But when you read it as bronchiectasis, your brain is happy. It's like, yeah, bronchiectasis, I know that, easy. Which one of these other random ones doesn't cause it? Oh, it must be B. I don't know, let's guess. You see the kind of process your brain does? MSRA is too important to guess. It's too important to miss these technique things. And if you are coming on the live course, we're going to drill this out of you because it makes such a huge difference. So let's quickly review then the causes. So we all know all these from med school, really. We've got all the respiratory causes: lung cancer, lung abscess, empyema, bronchiectasis, fibrosing alveolitis, CF, pulmonary fibrosis, for example. GI causes: inflammatory bowel disease, hence your Crohn's or ulcerative colitis. See, again, the funny thing about your brain is it's learned IBD, so it may not see ulcerative colitis for some reason as a cause of clubbing. Just put an X in the comment if that is you. Like, you've just looked at ulcerative colitis, but you haven't read it as IBD, but you knew IBD causes clubbing. Yeah, see how many X's are coming in? It's just amazing what your brain does. And that's why people don't get questions on clubbing wrong because of knowledge. They get it wrong on things like technique. The easier the clinical, the more likely the technique gets you wrong. Cardiovascular causes: endocarditis, congenital heart disease, atrial myxoma, classic things to remember for an exam. And then you've got your general causes: familial or congenital, pregnancy, and then your thyroid acropathy as well. So we all know this, or we just need to revise it. It's been there before in our head, but don't get these questions wrong because of technique. Next, SJT. Let's switch brains again. Let's go. First answers are it. Okay, 10 seconds. Put something down. Brilliant. Thank you, guys. Firstly, thank you for taking the time to think about these things because I know you're probably tired, exhausted, and your brain doesn't want to do this. But well done for doing it. Well done for focusing. Well done for giving it a go. I know it's not easy at this time, no, but it is going to be worth your while, I promise. This is the suggested answer. And I'm really happy to say that a lot more of you have got the suggested answer in this question than you did in the previous ranking question. So some of these things are starting to seep in, which is really good. There are a couple of people who've got differences, but a lot more synergy coming up with the answer. So let's break this down then. You want to train, announce the patient has collapsed, an inquiry is made as to whether there are any medical personnel on board. So remember, we are duty bound to go and help if we are asked to help. The passenger is traveling alone, reported to be conscious. The next stop is where you are due to get off. It's only 10 minutes away, and there is said to be paramedics already waiting there. You're planning to meet a friend for lunch, and you worry if you attend to the passenger, you will be delayed. Rank or mindset, this or this or this or this. B, take a history, examine her, wait with her, hand over to the paramedics. By far the best thing. Most of you put B as number one. That makes sense. C, so you throw that out the window. Done. C, take a detailed history, leave a written note for the paramedics explaining you had to dash. Obviously, this is good, but it's not as good as handing it over directly. Therefore, it comes below B. D, offer to review her briefly and then leave as soon as the train arrives. At least in this option, because remember, you've got to choose out of these three now. So between D, A, and E, the only one where the end goal is achieved, that you've at least seen her, is D. So D has to come better than A and E because at least you lay eyes on this patient. It's a brief one, you leave straight away, there's no handover, agreed. But it's better than A and E because in A and E, you haven't done anything at all to even assess that patient. It might be an emergency. So D has to come next. There's quite a few people who've put this the other way around, A and E. Let's quickly talk about why A and E are this way around. Look at this from a, what's my overall goal? Now, you're not meeting the goal of seeing the patient, so both of those are equally bad from that point of view. So now you've got to see, is there anything in any of these statements that may even make things worse? Forget not helping. Does it make things worse? A, pretend you have not heard, as surely there were other medical personnel on board. Not very good, dishonest, not helping out the patient, clearly not good. E, apologize that you can't review her without your doctor's bag, which is not true. You can review her without a doctor's bag. So that's not great anyway. But encourage her to see her own GP later that day rather than see the paramedics. Now, when you read that clearly, can you see why that is even worse than not doing anything? Because you're actively telling her to not see the paramedics and see your GP later. What if she's having a stroke? And you've told her, don't see the paramedics, go to your GP. Can you see how that is actually from a C number one point of view, clinical, safety, that is worse than A. At least with A, you've not interfered and made things worse. You just haven't gone in and done an assessment. In E, you've done something really unsafe. You've given advice without even seeing a patient. Now, for those of you who put E and A the other way around, I'm not worried. That's why you do these webinars, to understand these things. But can you see why it cannot be that way around? Just put an X in the comment if you put it the other way around, and you can see why it can't be, because you're actively promoting possible harm. Excellent. That is why these webinars are so important. Yeah? Good. Excellent. I would never have seen that before. Good. That's why you do these things. Simple things make a difference. Okay. Last question of the webinar. Let's go. Pratika, just send us an email. Send us an email. Sorry, Pritika. Pritika, send us an email. Good. Samantha's coming in. Thank you. Ten seconds. Okay, that is time. Well done. Thank you, everybody, for giving your brains a workout for the last time. Let's quickly look at the suggested answer then. Before we do, by the way, some of you guys are saying, when is the 3-week booster? Just going to put a link in the chat right now. The 3-week booster webinar is 16th of December, where we'll pick up these technique issues and we'll bring them back again with some more questions and just see how much you've improved. So please do register for that. That's on the 16th of December. That's for the January exam. We'll also be doing a 3-week booster for the February exam, now that there's a February exam as well. So in theory, you can join both. So keep an eye on the website for the second one as well. But you can join directly for the 16th December 3-week booster webinar as well if you want to. Okay, so CEH. A lot more of you got the same combination as what we've written here in this question than you did in the previous questions. That's really, really good to see. Let's break it down. FY2 doctor, gastro ward. You witnessed the registrar raising her voice at the FY1 doctor on the ward round. She is annoyed that the FY1, has not summarized properly the notes for the patient. The FY1 doctor initially appears upset, although then carries on with the ward round as normal. Remember, you're looking at an and approach now. I'm going to do this and this and this. In totality, I'm going to take this story forward, thinking about multiple endpoints. There's no point choosing two things that basically do the same thing. It's three different things, looking at it from all views. So we'll look at the right ones and then look at the ones that are not suggested as right. Number one, speak to the FY1 doctor in private after the ward round to check how she's feeling. Mentoring, she's your junior colleague, finding out how she is, maybe offering support, all very good things. E, speak to the registrar later in the day, discussing your concerns for how she spoke to your colleague. Very good. You're going to the source, you're talking to the registrar. Maybe the registrar is having a pretty tough time. Maybe the registrar has got stress. Maybe it's just the sign that they're struggling, for example. So you've got to talk to the registrar. No point going straight to a consultant yet, because you haven't even been to the person in front of you. So for example, B is not a great option yet because you haven't taken the step in between, which is talk to the person. Maybe then when you go to the consultant, you can offer some support or talk about the registrar struggling or whatever it might be. You only go directly to consultants if there are patient safety issues. There's nothing to suggest that yet. H, offer to help teach the FY1 doctor about good medical documentation. Really good, talking about supporting junior colleagues, being the kind of role model that you're supposed to be as a senior clinician, helping your peers, etc., etc. Three very good things, but can you see how three very different endpoints? Number one, you've approached the problem. You've gone to the source. You've talked about it with the right person in the appropriate way to try and work out what you need to do next. Number two, you've made sure empathetically your colleague is okay with what happened. And number three, you're offering to help her improve her own game in terms of documentation because she's an F1 and maybe she can do with some help. These three things in combination take the story best in three different endpoints. Let's look at the others. A, choose not to get involved. I'm glad not many of you, in fact, I don't think any of you put A, you can't just ignore. B, we've talked about why going straight to a consultant is not the best thing at this point because you haven't really got grounds to do it and they've probably got thousands of other things that they're dealing with at this point. D, confront the registrar for their inappropriate tone during the ward round. Again, it's doing the right thing in terms of going to the right person, but you've got a much better option later in the day rather than in the ward round. And the word confront there is a big word. Like there's no point bringing it up there and then unless you haven't got any other option. If you haven't got another option, then you've got to find a way to talk to the registrar. Then you might have to choose that one. But you have got a better option and therefore it's not the best. Again, a lot of people F, give poor feedback on the registrar's anonymous multidisciplinary feedback. Sounds good, reasonable, pretty good thing to do. Is it going to make any impact whatsoever now? No. Could she get annoyed with many other FY1s in the meantime? Yes. Could there be problems that she's having, the registrar's having, he's having, and we don't pick that up and we can't support them? Yes. That's why this is nice, but it's not nice now. What sounds good versus what sounds good now. That now is the most important thing. Encourage the FY1 to feedback badly on the MDF. Can't do that. Number one, again, is time. But number two, you can't influence how somebody fills out a questionnaire. Like it's just unethical. Like they need to do it how they do it. You can't suggest they do this. Otherwise, it's not going to be anonymous, which is how it's supposed to be. And then, like we said, C, E, and F, therefore, end up being the most appropriate options. Good. Well done. So this has really highlighted the C's that we talked about, and some of them came into play in this question, didn't they? So firstly, SJT and or. If you don't get this bit right, forget everything else. You have to get your mind in the right place. Am I looking or? Am I thinking and? If you don't get that bit right, everything else is tough because the lens that you're looking through is incorrect. 4 C's, clinical, convenience, communication, colleague support. We talk about these in much more detail on the course and on the videos, but at least be aware of them from the webinar. And this is really important. I think hopefully you guys have picked this up today. What seems right versus what seems right now. Super, super important to get your endpoint thinking on point. Otherwise, it's just like what sounds right. Going back to clinical, we showed a few things about clinical technique as well. Much more like this again on the live course on the 18th of December is clinical day. Convert double words to single words. Small words, don't miss them. We haven't missed a few already this webinar. Soft words versus hard words and how important they are to pick up and making sure every single word counts. 6 weeks to go if you're doing January, slightly longer if you're doing February. MSRA daily planners, download them, print them, tick them off day by day. I promise you, it takes the pressure off thinking, how am I going to get through everything? If you've got a plan, then it goes forward. Dual-based approach, questions, understanding. Don't just do thousands of questions every day. It doesn't do anything for knowledge. You have a lot of gaps. Don't just read every day and read guidelines and guidelines and guidelines. It doesn't do anything for your technique. You need a dual-based approach. Every day you should be doing some questions. Every day you should be doing some background learning, whether it's watching videos, listening to audio, reading guidelines, something to boost knowledge, something to boost technique. If you do a little bit of that every single day, you're going to climb that ladder pretty quickly. And if you have the package, both of it's covered. Two sources of questions. Don't just rely on one question bank. If you rely on one question bank, you start to learn how to answer their questions because you get used to their question style. Then you walk into an exam, boom, different questions, different style, different writers, completely changes the game. Your brain is too used to one style. Use a second source of questions. If you bought the package today, you've probably already got a different question bank. When you combine the two, your brain is going to be ready for anything that is thrown at you. Technique focus, smart learning. Don't just learn thousands of things. Learn 2 or 3 important technique things that can change 10 questions. Hopefully already today we've given you some exposure to how technique makes a big difference. If you imagine if you iron out 2 or 3 of those things, how many times that's going to happen in the exam, how many more marks you're going to buy yourself. Smart learning, not just volume of learning. GMC Good Medical Practice, we cover that in detail in the SJT course, the live course, the video course, the audiobooks, the flashcards. You need to know these principles in order for you to apply those 4 C's that we talked about earlier on. Make sure you know your chronic disease guidelines from NICE. We have covered all of these in the videos, the audios, the flashcards. Make sure you're on top of these because they will ask these in an exam like MSRA. We haven't done cancer referral guidelines today. You need to know these because if you don't, they're going to think, really, as an ST1 doctor, you would have missed that potential cancer. You need to know these. If nothing, they're on YouTube. We've got them all over our YouTube channel, but they're definitely in our courses. Make sure you join the Telegram group. Links have gone out multiple times in the chat. Scroll up and you'll find that. 3-week booster webinar, 16th of August. For those taking the January sitting, there'll be another, it's not 16th of August, sorry, 16th December, 16th December, not 16th of August. For the January sitting, there will be a webinar in January for the February sitting as well. Stay tuned to the website and the events page and the Instagram to get those dates. 2-day live course, like we said, 17th and 18th of December. 17th is SJT day. 18th is clinical day. You'll get watchbacks to these until either Jan or Feb, depending on when you do the exam. There are the planners. Hopefully you're going to use those. That's the Telegram group. Hopefully we're going to see you on there. Those are the social media links, particularly Instagram and YouTube. Thank you guys for your time tonight. Amazing turnout. Close to 300 people on this webinar. Really glad that you stuck it out. Really hope it was helpful. Thank you to everybody who's answered, asked questions, volunteered, got involved, put X's in the chat. These webinars do not work without you. Hopefully we'll see you guys in 3 weeks' time for the next one. Hopefully we'll see you on the live course on the 17th and 18th of December. And hopefully we'll see you in the Telegram group and on social media as well. That is the coupon. Like we said, there are 15 coupons available. I don't know how many have gone. They've been pinging throughout this webinar, so I don't know if there's some left, but there are 15 available. They'll run out at midnight if they don't run out before. Videos, live, audios, question banks, mock exams, flashcards, the works, knowledge and technique covered. Thank you so much for your time this evening. I wish you a super day, evening, night, afternoon, depending on where you are in the world. If you're doing nights, I hope some of the stuff you learned today is going to help you even overnight. Take care. Have a super evening. Hashtag Campus will pass. We will see you soon. The YouTube channel is just called Dr. Aman Arora. Just search Dr. Aman Arora and we will see you on there. Take care. Have a super evening. See you soon. Thanks, Dr. Pooja, for all the questions she's been answering. I know she's been busy throughout the whole webinar. We'll see her as well on the webinar in 3 weeks' time. Take care.